So in this video, we're going to take a quick introductory look at ventilation perfusion coupling. Now you may see it written in your textbooks as ventilation perfusion matching or VQ coupling or VQ matching. It's all the same thing. Now, to put it into context, what are we referring to? We're basically referring to the events of gas exchange that happens at your alveoli with the blood flowing past your alveoli. Okay, that's what we're referring to. So that means, remember the 4 phases of breathing? You've got ventilation, air coming into and out of your lungs. You have external respiration, where gas is exchanged at your alveoli to the capillaries and vice versa. You have gas transport, where oxygen and carbon dioxide is transported through your circulatory system. And you have internal respiration, where gas is exchanged at the tissues of your body. Okay, so what we're referring to today is gas being exchanged at your alveoli with your blood that's going past, so your pulmonary blood supply. Firstly, let's go back and let's define ventilation and let's define perfusion. Okay, first thing is ventilation. Ventilation is the amount of gas that gets to your alveoli every minute that can participate in gas exchange. Okay, so simply put, ventilation is the amount of gas in your alveoli. That's ventilation, okay? For example, if I were to draw an alveoli up, it's the amount of gas coming in and out of this alveoli every minute. So that is ventilation. This gas, you know, wants to move across the respiratory membrane, and the oxygen wants to jump into the blood and the carbon dioxide wants to jump out of the blood so it can be breathed out. That's ventilation. Perfusion is the amount of blood that moves past the alveoli every minute that can participate in gas exchange. So you have blood moving past, and this blood can either pick up oxygen or drop off carbon dioxide or do both, and this blood that's going past is what we refer to as perfusion. So perfusion is the amount of blood moving past alveoli that can also participate in gas exchange. Okay, so that's the first point. We've now defined what we're referring to. Next thing is this. Why is it called coupling? It's called coupling or matching because we want there to be a near perfect match, meaning of the gas that comes into the alveoli, we want there to be enough blood to go past that can take that gas away or to give the carbon dioxide away. So let me give you a nice example. Let's just say we inspire some air and we have in that inspired air 100 units of oxygen. Okay, so we'll just say 100 units of oxygen, whatever that may mean. And let's just say of the blood that's going past, we have 100 carrier units of oxygen, so basically hemoglobin. But you know that one hemoglobin carries far more than one oxygen, but for simplicity's sake, let's just say that one carrier carries one oxygen. Now what you can see here is if we have 100 units of oxygen coming into the alveoli and 100 units, carrier units, coming past in the blood, this is a perfect match. It's 1 for 1. For every gas that jumps into the blood, we have a carrier molecule that can take it away. This is what we refer to as matching, and our lungs want this matching to be near perfect. Now in actual fact, if you have a look, you'll see that of the amount of gas that comes through, so for your ventilation per minute, you'll find that the amount of gas that comes in is around about 4.2 litres, okay? And the amount of blood that moves past, which is your cardiac output, so the amount of blood moving past per minute is 5 litres. So if we do the ventilation perfusion ratio, which is V over Q, so remember the V is ventilation and the Q is perfusion. If we have a look at this, what is it? The ventilation is 4.2. The perfusion is 5. If you have a look at that, which is 8.4 to 10, which is nearly 1 to 1. In actual fact, it's around about 0.8. instead of 1, okay? But it's close. So what you can see is there's a near match for the ventilated air compared to the blood that's perfusing past, okay? And your body wants to keep it like this. So let's talk about what happens when things go wrong. So let's just say there's some anatomical or functional issue in which ventilation drops, or let's just say what happens if perfusion were to drop. So let's have a look. First thing you need to be aware of is the amount or the partial pressure of gases, throwing stuff all over the place, the partial pressure of gases, not just in the atmosphere, but in your alveoli and in your blood. So let's first talk about partial pressures and what that truly refers to. Partial pressure. Well, in the atmosphere that we breathe, in the air that we breathe right now, there is a certain amount of pressure being forced upon us, okay? And this is just the sum total of all the gases in this atmosphere pressing down on us. What are these gases? Well, these gases are nitrogen. These gases are oxygen. These gases are carbon dioxide. And there's some other trace gases that are there. So these are the main gases that we're breathing in right now and that are in the atmosphere. Now, the pressure on us right now is actually 760 millimeters of mercury. That's the amount of pressure. Your question may be, how come I'm not feeling this pressure? Well, you're born into it, so of course you're not going to feel it. You have 760 millimeters of mercury pressure placed upon you now, and it's the sum total of the individual gases. So, of all the gas, you'll find that about 79% is nitrogen. You'll find that around about 21% is oxygen. And you'll find around about 0.03% is carbon dioxide. So there's not much carbon dioxide in the air that we're breathing right now. Now, that means that if I were to take 79% of 760, I have the partial pressure of nitrogen in the atmosphere. Okay? And we would write that as P N2. And let's just see if we were to calculate that. The partial pressure would be around about 600 millimeters of mercury. Okay? If we were to calculate the partial pressure of oxygen in the atmosphere, 21% of 760 is around about the partial pressure of oxygen. It's around about 159 millimeters of mercury. If we were to calculate the partial pressure of carbon dioxide in the atmosphere, 0.03% of 760, you'll find that the partial pressure of carbon dioxide is around about 0.2 millimeters of mercury. Okay? So that means that outside in the air, so you know that nitrogen we don't need to worry about, so let's forget about that. I've spoken about in the lectures why we don't care about nitrogen. Firstly, it's an inert gas, so it doesn't really react very well, and there's no strong pressure gradient for it to dissolve within our blood or into our tissues, unless you're deep sea diving, and then the pressures change. But that's for another discussion. So, let's just say out in the atmosphere now, the atmospheric pressure is, for oxygen, 159, for carbon dioxide, 0.2. Now, we breathe that air in. That 159 millimeters of mercury comes into the lungs, that 0.2 millimeters of mercury carbon dioxide comes into our lungs, but the amount of gas, the partial pressure of these gases change. So what you'll find is by the time this gas reaches your lungs, that the partial pressure of oxygen is actually 100 millimeters of mercury. Okay? And because some of that oxygen is being mixed with water, because we're humidifying some of this air, and some of this oxygen is being lost via other means. So that partial pressure of oxygen drops. You'll also find the level of carbon dioxide. So the partial pressure of CO2 goes from being 0.2, goes all the way up to 40 millimeters of mercury. Why does it jump up so high? Well, because this blood going past continually throws carbon dioxide in here. So this alveoli is like a little chamber for CO2. CO2 being thrown in, so 0.2 coming in, but it's mixing with the higher CO2 that's coming from the blood. Okay? Now, next point is that the blood going past, this blood wants to pick up oxygen, so oxygen wants to go in this direction, okay? And carbon dioxide wants to go into the alveoli, so in this direction. Now, gases will only move down their pressure gradient, which means if oxygen is 100 millimeters of mercury in the alveoli, it must be something less in the pulmonary artery going past, and it is. So, partial pressure of oxygen in the pulmonary artery is 40 millimeters of mercury. Okay? Which means oxygen can jump in. Carbon dioxide, the partial pressure of CO2, well, is it going to be more or less in the blood? Has to be more because the CO2 wants to jump into the alveoli, go downhill. So, the partial pressure in the blood is 45 millimeters of mercury. Now look at the differences. There is a difference for oxygen, 100 to 40, which is a 60 millimeter mercury difference. And from carbon dioxide, from the alveoli to the blood, is only a 5 millimeter of mercury difference. But did you know that the same amount of oxygen and CO2 gets exchanged? Now, you'd think, well, wouldn't there be more oxygen exchanged than CO2 because of the pressure is so much greater, that there's a stronger push behind oxygen compared to carbon dioxide? And the answer is yes, but remember, carbon dioxide is about 20 times more soluble in liquid than oxygen is. So carbon dioxide does not need much of a push to go across that respiratory membrane. Okay? Now, that's the first point. This is what happens normally. And you get this nice matching for the air that comes in, for the ventilation, it matches with the perfusion and everything's fine. But let's just say something's happened and a patient, a child comes in and they've inhaled a peanut. And that peanut gets trapped and blocks an airway. Well, let's think about what happens. If this peanut comes in and blocks an airway, that means the ventilation is going to drop, right? Because it's blocked, no air can come in and no air can go out, so ventilation drops. Now, what happens in your body is, at your lungs specifically, is quite amazing, because when this drops, right, think about it, let's just say we had that 100 units of oxygen and the 100 units of blood going past to pick it up. Well, now that we've blocked it, this is going to drop. Let's just say this goes down to 10 units of oxygen. But we still have 100 units of blood going past. So what are we wasting? We are wasting the blood that's going past. Now this blood could be used elsewhere. This blood could be redirected to parts of the lung which are well ventilated, not poorly ventilated. So what the body does is, again, it wants to match. It wants to create this coupling. So I want you to think about, how could we create a match? If ventilation drops, how could we make perfusion match that? Well, we drop perfusion. We drop the amount of blood that goes past. How do we do that? Well, we vasoconstrict. So we tell this blood vessel to constrict. And if that happens, less blood goes past and it starts to match. Now the good thing about this, is that if you constrict this blood vessel, the blood gets pushed back, which means it gets redirected to other alveoli that are well ventilated. So perfect. So, how does this mechanism occur? If you have a drop in ventilation due to some sort of block at your alveoli, how do we get this constriction? Well, what you find is, when this alveoli is blocked, that means that this gas is trapped in a way. So it can't go in and out of the atmosphere, okay, or in and out of the alveoli and exchange with the atmosphere. So the level of oxygen that's in this alveoli can only go one place, and that's into the blood. So that means the concentration or partial pressure of oxygen drops because it'll jump into the blood. What about CO2? Well, as the CO2 goes past, it's going downhill. It's trapped here, so CO2 will jump into the alveoli. So CO2 here will go up. What you'll find is a drop in ventilation equals a drop in the partial pressure of oxygen in the alveoli. Right? And what this results in is the drop in oxygen is what stimulates. It's the drop in oxygen that stimulates vasoconstriction. It's the oxygen that stimulates vasoconstriction. Okay, hopefully that makes sense. So it's starting to match. Now I want to talk about what happens if something blocks the blood flow going through. So dropping the perfusion. So let's have a look. So remove that. Get rid of the peanut. Airways are nice and clear. Let's keep this up here, but let's write it a bit neater. So let's make the statement that a drop in ventilation equals a drop in alveolar oxygen, which equals vasoconstriction, which equals a drop in perfusion. Okay? Now let's just say that this person, ventilation is fine, it's perfect, the airways are well ventilated, but they've got a blood clot. They have a pulmonary embolism that has come past and is now occluding that vessel. So think about what happens. The blood flow is now stopped. Now, of this blood flow that stopped, remember, this ventilation is fine. So this blood flow stops, which now means that the oxygen cannot jump into the blood because there's no blood to exchange with. The CO2, cannot jump out of the blood. So all that's happening is air is going in, out, in, out, in, out, in, out. Now, if that continues to happen, these values start to look more like the values in the atmosphere because nothing's being exchanged, right? So as you breathe in, out, in, out, in, out, what you'll find is that the oxygen is no longer 100. It starts to shift its way to 159. Let's just say 150 because it's not going to be exactly. And the carbon dioxide shifts down to nearly zero, so virtually 0.2 millimeters of mercury. So what has happened? You've had an increase in oxygen, but you've had a drastic decrease in CO2. And this is because of the occlusion. So what you'll find is, this point now, is that so that's the first point. Second point is that a drop in perfusion resulted in a drop in alveolar CO2. Let's change colours so that you don't get it confused with this one. A drop in perfusion because of the clot resulted in a drop in alveolar CO2, and this results in, how are we going to match it? This is dropped. What do we want to do? We want to drop this. So we want to bronchoconstrict. So a drop in alveolar CO2 equals bronchoconstriction, which equals a drop in ventilation. Okay? So, what are the major points? What's the take-home point? Two take-home points. First take-home point is ventilation wants to match perfusion, and perfusion wants to match ventilation, because then you get an adequate amount of oxygen in your blood that can be delivered to tissues and get rid of an adequate amount of CO2 via expiration. If you have some sort of problem that's obstructing your airways or obstructing your blood flow, your body responds, your lungs respond to try and make it match. And overall, you'll find that a drop in ventilation will result in a drop in perfusion. The drop in ventilation will result in a drop in oxygen in the alveolar. This drop in oxygen in the alveolar results in vasoconstriction. Next point is, if there's a drop in perfusion, we want to get a drop in ventilation, okay? And that the drop in ventilation results in a drop in carbon dioxide. This results in bronchoconstriction. So, CO2 is responsible for changing the diameter of the airways, and O2 is responsible for changing the diameter of the blood vessels. I'm sorry that took so long, but I hope that makes sense.